Welcome, everyone. We'll give Zoom just a moment to catch up as it lets everyone in. And I will just offer a very quick proviso at the beginning of today's session. So today's session is part of a larger project, the Trauma Responsive Congregations Project. And the way this one is set up is that the first hour, so from 12:30 to 1:30 Eastern, it's a totally public session. We'll have Q&A around 1:15 or so, and everyone is welcome to be part of that. And then at 1:30, we will go just to the project participants. And so we'll, of course, indicate when that time has come, and we would just invite everyone to close down Zoom. You can go about your day, and we'll move into just the specifically project participants only part of the event at that point. All right, Shelley, I'll turn it to you.
Thank you, Michael. Welcome to all of you who have taken time to be here today. My name is Shelley Rambo. My pronouns are she, her. I want to welcome you to this webinar. As Michael said, it's a collaboration between the lab and Boston University's Trauma Responsive Congregations program, which is funded by Lilly Endowment. This, for those in the program, this is our monthly learning session for the program, and we're delighted to expand the scope and to offer it to chaplains, faith leaders, and all others who are interested in learning more about trauma-informed spiritual care. The TRC program aims to support urban congregations in their efforts to address trauma within their various contexts and communities. So again, we want to say we're so glad that you are here. Dr. Eric M. Brown is our speaker today, and Dr. Brown is associate professor and a core faculty at Boston University School of Medicine in the Mental Health Counseling and Behavioral Medicine program. Dr. Brown has worked in various clinical settings, level 1 trauma hospitals, community mental health counseling centers, and in private practice. He provides consultation and trainings for congregations and other spiritual communities on topics related to trauma and trauma-informed care. You can explore his bio in more detail. I'm hoping that we can just pop it in the chat if you want to read more about his work. So we're very pleased to have him not only as a speaker today, but as a consultant for our program. Dr. Brown, we're excited to learn from you in this session, which is focused on adverse childhood experiences as it connects to spiritual and religious leaders and care providers. So welcome, we're excited to learn from you.
Thank you. And hi, everyone. I'm Mary Paige Wilson-Lyons. My pronouns are she, her. And I'm just here to remind everybody, I'm a PhD student at Boston University studying theology and mental health. I'm just here to remind everybody that we will have a Q&A session at the end. And so while you're listening to Dr. Brown's presentation, if you just want to pop any questions into the chat, we will definitely get to those after the presentation. And so now, Dr. Brown, please take it away.
Thank you all. I'm so glad to be here. Need to make one correction to what Shelley said. I'm an assistant professor, not an associate. I'm hoping for that, but you know, it's always better, Shelley, to go up than down, right? So I am very happy to be here. I just want to start out. Those are a picture of my parents. In African-American culture, quite often, when I meet people, they say, "Who are your people?" So these are my people, and I'm showing you this for several reasons. One, to just let you know where I'm coming from. My dad and mother both have ministered and pastored churches for, well, it's been over 40 years, over 40 years now. Mother worked in the public school system. My dad is a bivocational pastor and also did some chaplaincy work, volunteer chaplaincy work at a prison. And me, myself, something I didn't put in the bio, but I was a full-time senior pastor for 11 years before I went into academia. And I am actually doing some volunteer work, getting ready to start that here in a few weeks at the Boston Medical Center. I've done some volunteer chaplaincy work in hospitals previously as well. So I really have a passion for speaking to you all today about what is considered by many to be one of the most significant public health studies over the past 25 years. A few things that I'm hoping to do this presentation. One is just to help you understand how one's experiences in childhood may influence one's mental, emotional, and physical well-being throughout their lifespan. So I probably should have given this a better title. When you say adverse childhood experiences, people think it's more so about children. But this presentation is going to show how these experiences in childhood, both adverse and positive, how they actually have long-lasting influences. Hoping to provide you a framework for understanding maybe some of your own susceptibility to burnout, right? We know that's always been an issue, certainly since COVID. And then number three, identify ways in which we can create growth fostering relationships, because the key to healing adverse childhood relationships, experiences, is growth fostering, what I'm calling growth fostering relationships. And so I'm going to go on for about 40 minutes. And again, if you have any questions, put it in the chat and we will discuss those. Okay. First thing I want to do is have, if I can get you at least to put in both the PCE, the positive child experience, and the ACEs assessment as one document. The positive child experience questionnaire, that's the first page. The ACEs is the second page. I just want you to go through these items, okay? They both work the same way, okay? If you had these events happen with the positive child experiences, it says if this was true most of the time for you, just check it and put a 1. You won't be able to mark on the document. It's a PDF, so you might just make a note on the side. Just calculate those positive child experiences and how many of those, I believe there's 7 of them, how many of those were true for you most of the time, okay? Just go through that and read that and then just write your number on the side. It'll be 0 to 7. And then the second page will be the adverse child experiences. And those are events that could have happened to you even once, okay? And again, the answer is just 1, right? You get a 1 for each of those items. Some people say, well, what if both my parents struggle with a mental health disorder? You still only get a 1 for that item. So let me give you a few minutes to answer that before we begin. Someone said they don't see the assessment. There's a link that says the link doesn't work. The link is working on my end. I don't know. Is it made public, Elise?
Let me try again.
Okay. Looks like it's working for some. All right, and okay, put the PDF there as well. You don't have to have answered these to hopefully benefit from the presentation, but just wanted to give you those items. All right. Since you just put the PDF, let me give 1 more minute. Shouldn't take too long. And I am not, I should have said this from the beginning, I am not asking anyone to share their ACEs or PCE score. And it is just 1 questionnaire for both of those, correct? Both of those. I am going to read through all of them. There's a slide that's going to have all of them there. So I will do that. Okay. Some things that aren't listed that are adverse. True, it's very true. Agree, and we'll talk about that as well. All right, let me jump into the presentation and then we can talk some more about some of these comments or questions. So it was back in the 1990s, Dr. Folletti, a physician in California, as he was going through some assessments with his patients, he was actually surprised, as a male doctor, he was surprised how many of his female patients had suffered from sexual assault. And he began to see some patterns between sexual assault and other adverse childhood experiences, honestly, that seemed to have really long-lasting effects on their physiology, okay, on their biology. He and the CDC came up with these 10 items, and these are the 10 items people were asking the questions for. Did you experience physical abuse between 0 and 18, right? Birth and 18, emotional abuse, sexual abuse. They came up with these 10 items, and they first gave them to a group of people in San Diego. They were mainly white, mostly white, very middle-class persons, okay, who were adults. And what they found was that the number of items you may have experienced as a child had significant mental and biological effects well into adulthood, okay? Since this time, I mean, there are literally thousands of studies that have been done on ACEs all around the world with diverse people groups, and they found the negative mental and physical effects and emotional effects and relational effects. They have found this across the board. It doesn't matter what your race, your ethnicity, your socioeconomic status is. Now, oftentimes when I do this presentation, I've done it across the country. People will say, well, aren't some of these things, don't some of these items have more consequences than others? Originally, they didn't really look at that. Each item is ranked 1, okay? Over the past 5 years, actually, they have found through some research that abuse and neglect seems to have even more adverse consequences than some of the household challenges. That's not to say that the household challenges don't matter, but it's the abuse and the neglect that actually even outweighs some of those household challenges. What I'm going to do in this presentation is I'm going to just go really briefly over some of the research that shows how these early childhood adverse experiences actually have very long-lasting effects well into adulthood and our older years in life. So these are just some of the effects, okay? We know persons with higher adverse childhood experiences, there's a tendency for there to be a lack of physical activity, more likely to smoke or be addicted to drugs or alcohol, right? Missed work. There's several physical and mental health effects or consequences to having a higher number of adverse childhood experiences. Originally, for the first probably 10 or 15 years, the score, the adverse child experience score that was most concerning was if a person had 4 or more. Now, studies of children, right, people who are still children, who are going through ACEs, they found even having 2 can have significant adverse experiences. So this is the prevalence, right? This was true back in 1999 or 1998 with Folletti's original publication. But if you look at the CDC website, it looks like these percentages still hold true. So about 36% of the population have no ACEs, or they report that. 26% of, this is the United States, reported 1 ACEs. About 16% reported 2 ACEs. About 10% reported 3, and about 13% reported 4 or more. And what we found is that the people who have 4 or more, the numbers tend to be really, really high, okay? And so again, a lot of the research has shown that if you have a score of 4 or more, that's when concern really, really occurs. Now, let me pause and say this, and I need to really stress this. ACEs is not your destiny, okay? First of all, we're going to talk about positive childhood experiences toward the end, and they have shown to be protective factors. Positive childhood experiences Another item is benevolent child experiences. Those are newer studies, okay, but they have shown to be protective factors. And so we'll look at those. If you're having a high PCE score, that'll serve as a protective factor. But what we found, and this is not surprising, people who have really high ACEs scores tend not to have as high PCE scores, okay, or positive child experience scores. So let me just go with a few studies on just children with ACEs. Children with 2 or more ACEs are more likely to qualify for special health care needs and repeated grade in school, right? ACEs abuse or household dysfunction is often associated with interpersonal violence perpetration, right? And children struggle, right, in school with all of these matters such as delinquency, violence, weapon carrying. Youth with 2 or more significantly are likely to report cognitive difficulties or depressions, right? Females much more so than males. And again, I'm just going to just jump through these really quickly because I want to give you the breadth and the scope of the consequences of ACEs. We know with children that 2 or more ACEs, I mean, the possibility of suicide and non-suicidal injury goes up significantly. Again, we do know that women in general, and we see here female youth are more likely to suffer from depression. 2 or more significantly, they predict alcohol, marijuana, or substance use or intoxication at school. 2 or more significantly more likely, with youth, they are more likely versus those without any ACEs to report being victims of school violence, have engaged in fights or carry weapons. What I should have said before, and I'll say it here, that what they found with both ACEs and positive childhood experiences is it is a dose-by-dose response, okay? So each one of those numbers, right, as the number goes up, the likelihood of there being mental or physical problems goes up substantially, okay? And I'll give you a few statistics on that later, right? So again, around 15% have indicated 4 or more ACEs, right? And this increases all kind of chronic physical, emotional, and relational pain. A lot of people who are on pain medications for a long period of time, a lot of those persons have higher ACEs scores. Right? A person with 4 or more, they're more likely to engage in risky sexual behaviors, become addicted to substances, and even have an early death. I have a slide later on about just the increased likelihood of being in relationships where interpersonal violence is at play. I need to pause here. I've done this presentation again several times, particularly since COVID in 2020. And this presentation is offensive to a lot of people, not the presentation itself, but the study of ACEs. There's something offensive about it to a number of people. And I think it's because in some ways this is deeply un-American, okay? And for 2 reasons. One is I think in general, as Americans, maybe particularly middle class and up Americans, we don't want to believe that the past should affect us in the present. And we certainly don't want to believe that the past might predict some things in our future. And we really don't want to believe that other people's choices, right, should affect us significantly well into the future, okay? So let me just say again, a person's ACE score is not their destiny, okay? But the research is really clear. Again, there are thousands of studies now looking at ACEs in various aspects of life, okay? And it shows that it really does have an effect, right? So I'm not going to go over this slide. It actually repeats some other things, but you'll have these slides and you'll see that a lot of our healthcare costs, right, are actually a result of adverse child experiences and how they affect people well into their older years. Now, I'm a mental health counselor by profession, so I came into this study really interested in the mental health and emotional effects, and this is where I believe it will touch on much of your work. And during our question time, we can talk about some of the applications to your specific vocations and callings. Depression and anxiety go up considerably, suicidal behavior, PTSD. So I need to say this, adversity is not the same thing as trauma. Some of you, I think were in a presentation earlier on trauma, right? Trauma is a response, all right? Trauma is a physiological and neurological response to extreme pain, life-threatening events, or events that threaten our bodily integrity, right? That's how we talk about sexual assault, okay? Adversity is not the same thing as trauma. Now, as you look through those adverse childhood experiences, some of those certainly are potentially traumatic experiences, okay? But what we found is that persons who have higher number of adverse childhood experiences, they are more likely to suffer from PTSD if a potentially traumatic event happens, okay? I've done some chaplaincy work in prisons, and there have been studies on ACEs in persons who are incarcerated, right? And those numbers are extremely high, extremely high. Effects on adult relationships. Results indicated that ACEs had a significant negative effect on adult relationship health for both men and women. A positive direct correlation, right? So there is a positive direct correlation between the frequency of childhood physical abuse and the risk of interpersonal violence, victimization for women, and IPV perpetration by men. Women were at increased risk of being victimized by IPV if they reported childhood sexual abuse and if they witnessed maternal IPV. We also know that men are much more likely to be perpetrators if they grew up seeing IPV. That's not to say that men are victims of it. We know that that's true as well. Okay. A friend of mine, actually, Naomi Wheeler at Virginia Commonwealth University, just came up with a study a few years ago, found that both men and women, this study was done on heterosexual couples, so it's limited by the fact that it's just heterosexual couples they were working with a program. They found that both men and women in these marital relationships were influenced by their partner's score. One score influences one's own relationship effort and their partner's relationship effort. The male ACEs score predicted the female's life satisfaction, and the female's ACEs score predicted the male relationship satisfaction, right? Potentially females who are in heterosexual marriages, they may not be surprised by this at all. We do know that lower income persons with higher ACEs, they indicated lower levels of relationship effort and satisfaction than their higher income peers with the same ACEs exposure, right? ACEs in career development. I teach the trauma counseling class here at Boston University's Medical School, and I teach the career counseling class as well. And I'm interested in how mental health and trauma really affect one's career development. There's a significant gap in employment during middle ages between individuals with and without a history of ACEs, along with significantly lower levels of education, employment, and assets across the lifespan. One study found that ACEs undermine a person's ability to attain employment, and that drug problems and depression symptoms exacerbate the link between ACEs and unemployment. Then finally, a study showed the impact of ACEs on long-term economic consequences. Survivors of physical abuse were 140 times more likely than non-survivors to be unemployed. Let me go back up. Sorry, I wanted to show something about the mental health, and I have this in the notes, and you'll so just to show you that dose response that I talked about before, how each number increase when it comes to ACEs, it really has a significant effect. When it comes to depression, persons with 4 ACEs, okay, talking about 4, 66% of women with 4 ACEs will suffer from depression, and 35% of men with 4 ACEs will suffer from depression versus only 12% of people with no ACEs, right, will suffer from depression. When it comes to suicide attempts, now catch this, If a person has 6 or more ACEs, right? If they have 6 or more, there is a 5,000% increase, all right, over those with 0 ACEs. I'll say that again. When it comes to suicide attempts, if a person has 6 or more ACEs, there is a 5,000% increase over those with 0 ACEs. When it comes to alcoholism, persons with 4 ACEs, right? Just talking about 4, I'm not even talking about more than that, just 4 ACEs, they are 7 times more likely than a person with no ACEs to suffer from alcoholism. Right? Injection drug use, person with 6 or more ACEs, they are 4,600% more likely, 4,600% more likely to suffer from injection drug use versus someone with no ACEs. And so that just shows you the devastating and lifelong effects that it can have, again, if a person does not have these protective factors. So let me pause, and I cannot stress this slide enough, okay? Please be mindful, do not reduce yourself nor anyone else to their ACEs score, all right? That's kind of the danger of this story. And this is part of, I think, the offense or the resistance to some of this research, because we have a tendency as human beings to reduce people, right? To label them. And that's one reason I'll say it now and I'll say it later. The importance of this presentation is not for you and your pastoral work or your chaplaincy work to go around finding everyone's ACEs score. Okay, I am not recommending doing that at all. Person's ACEs score, that is very personal. The reason this is such a public health study is I do believe those who are doing clinical care, right, mental health care, I do think they need to know the ACEs score, right? But I'm giving you this presentation just to help us understand why so many people struggle in the long term. We're all coming up with narratives, right? We all have narratives for why some people do well and some people don't do well, okay? And I think ACEs can actually help us understand this. I also want to say it's important for us to protect not only our own privacy, but the privacy of others. One of the problems with people's ACEs scores becoming more public, right, is that discrimination would be more likely to occur, okay? So I just needed to say that before I proceeded. Again, ACEs does not determine one's destiny. All right, let me just show you real quick a study that I conducted that was published a couple years ago. We looked at 506 mental health and school counselors, and we wanted to look at their ACEs scores, right? Their PCE scores and their likelihood for burnout, okay? What we found was what we thought would be true. Mental health counselors and school counselors both tend to have much higher ACEs scores on average than the average population. This wasn't a surprise. There was a social worker who did the same study with social work students, and they found this. We know that a lot of us come into this therapeutic work anyway as a result of our own pain, okay? So we did find that higher ACEs scores, they predicted lower satisfaction with work, compassion fatigue, as well as burnout. But we did find that PCEs moderated, right, or they lessened the negative effects of ACEs on burnout. What we found interesting with counselors and school counselors, and this isn't probably surprising, that even the counselors who had really high ACE scores, they tended to have really high PCE scores, right? So these were people who experienced a lot of pain, maybe growing up, but they also experienced a lot of positivity, meaning if you think back on those PCE questions, right, there were a number of people in their life who cared for them, and that might have had a lot to do with them coming into the profession. What we found very interesting, and I'll just make this statement, if you want to talk about it, we can talk about it during the question period. ACEs studies have shown, most studies show, that persons of color have higher ACEs scores than white persons. So racially minoritized persons tend to have higher ACEs scores than white persons. Now, some of that is controlled when you look by look at socioeconomic status, right? Persons of lower socioeconomic status, people who come from financial poverty, regardless of their race, they tend to have higher ACEs scores than people from middle class and upper class backgrounds, right? So I gave you those percentages at the beginning. I know there are some pastors here, I mean, working with urban congregations, maybe poor congregations. Those percentages of members who might have 4 or more ACEs, that's going to go up significantly if you are ministering, pastoring, or a chaplain for people who come from poor financial backgrounds. Okay, when it comes to male and female, those ACE scores, they're about equal. But what we found in our study, and I've talked to a few other researchers who found the same thing, is that racially minoritized counselors, their ACE scores were only a little bit higher, but they tended to suffer from burnout significantly less than white counselors. And female counselors suffer from burnout significantly less than male counselors. Okay, and we didn't assume that was going to happen, so we don't know exactly why. I have some assumptions on why that's true, and again, we can talk about that later if you'd like. All right. I also need to say this. There is a Philadelphia urban ACEs study. Some of you really should look this up. You can just Google it. Philadelphia urban ACEs study. What they did, and this started way back, maybe 15 years ago, when most of the studies were still looking at white persons. And so there was a group of people who came together and said, we assume, right, we think that there's more adversity. Someone had put that in the chat window. There's probably some adversity that people who are growing up in lower income environments, persons of color are experiencing, right? That are also, they're adverse, right? And they're probably also having negative health effects. And so they have a much more expanded ACE study. And what they found was that 37% of the Philadelphia ACEs study had experienced 4 or more ACEs. Okay, and that was with the expanded ACEs study. That doesn't have as much research. That's still newer in its beginning, but that's something you really need to be aware of. Okay, so we're going to get to the good news, the protective factors here. Again, this has only been maybe in the past 8 years that the CDC came up with these factors that if they happen to you in childhood, they tend to be protective. They tend to guard you from some of the negative effects of ACEs, even well into adulthood. And I think this is important. It's really important for us in a number of ways. If you talk to a public health professional, they say the real importance of ACEs is that we need to be advocating for children, right? We need to be advocating for our systems that serve children. The reason the protective factors, even these PCEs, are important is I think they give us an indication of what we need to be doing for adults as well, right? Who have high number of ACEs. Let me just pause to say this. Bessel van der Kolk, professor at the Boston University School of Medicine, wrote a really well-known book. Some of you certainly will have read it, The Body Keeps the Score. And he's focusing more on trauma, but he does have about 5 pages on ACEs. He talks about people who suffer from trauma, particularly children, and you see this with adults. They have problems with attention, they have problems with regulating emotion, and they have problems maintaining relationships, okay? That's particularly true for persons who suffer from what we call developmental trauma, that's childhood trauma, okay? So these are the 7 positive childhood experiences, right? Did you have the ability to talk to family and friends about your feelings? Did you feel that your experience of family was supportive during difficult times? Enjoyment and participation of community traditions, feeling of belonging in high school, feeling safe and protected by an adult at home, having at least 2 non-parent adults who genuinely cared about you, feeling of being supported by friends. Let me just say a few things here. When they've looked at these items, they found that the one item that even seems to outweigh, the other 6 is that having at least 2 non-parent adults who genuinely care. right? So this speaks so highly of mentoring. I think these 7 items speaks to the importance of youth groups, right? When we talk about in synagogues or mosques or churches, youth groups are extremely important in terms of providing these positive childhood experiences. Again, some studies that have recently come out, they found that positive child experiences also have a dose response effect, and they actually can help protect those with higher ACEs from depression and poor mental health. Higher PCEs resulted in adults reporting higher levels of present social and emotional support. And the reason this is important is this. We know one of the healing ingredients of adversity, stress, and trauma, those are 3 different things, is supportive relationships. But what we know is that if a person has a high number of ACEs, or if they have a lot of trauma, or even high stress over a long period of time, they tend to have fewer supportive relationships. Okay, so the disease works against the cure. All right, and I think this is really important for chaplains and pastors to understand that some people who might have a hard time in their own relationships, some people, quite honestly, that you might have a hard time relating to, are persons who may have high ACEs or high levels of trauma or prolonged stress. And so the disease can work against the cure, right? So I'm going to go to an anecdote for adults and just spend a few minutes here. Jean Baker Miller was a therapist, psychologist up here in the Boston area. And she and a group of women, feminist psychologists, they were talking about human development, particularly their own development and the development of their female clients. And what they found was contrary to what a lot of the male psychologists had said ever since Erik Erikson, like probably one of the more well-known. They noticed that a lot of the male psychologists, these were white male psychologists, a lot of them, they depicted healthy and mature development as growing more and more independent, right? So the more, the more a person matured, the more independent they became. They said, listen, this isn't true for us, and it's not true for our female clients. They began to understand and see that healthy, and certainly they weren't the first women to see this, that healthy development was characterized by interdependence, right? Interdependence, being able to relate well with others. Well, over time, there were some men of color who read this theory. They said, listen, this is true for us. And then there were white men who read it and say, hey, this is true for us as well. And so they came up with what we call relational cultural theory that is used quite often in therapy by counselors and psychologists and by people in other fields. So I just wanted to introduce this to you. There are several concepts. I'm just choosing 2. They talk about relational images. And these relational images, they derive from these deep memories of experiences in relationships, particularly those where the person was in the least powerful position. That's true for all children, okay? They're in the least powerful position. But that's also true for people who hold what we call these marginalized or these minoritized identities, right? Gender, sexual minorities, obviously racial minorities, socioeconomic, right? People who are in the less powerful position. These harmful or hurtful relationships, they stay with us from a young age, and they create this template for how we are going to relate to others. What they said is that we all, to some degree, some much more than others, we struggle with this central relational paradox, that as a result of these chronic disconnections, right, that we experience from a young age, people desire relationships, but they also fear engaging with others, right? So we have a tendency to hide certain aspects of who we are in order to keep the relationship intact, okay? And I think this is true for all of us. I can tell you, as someone who spent 11 years as a senior pastor, and now, I'm still consider myself a pastor, but mental health counselor, okay? I can sometimes choose whether or not I want to talk to someone in the Boston area in particular, right? If I tell them I'm a pastor, usually that conversation is shut down, okay? But if I tell them I'm a mental health counselor, then they open up. right? And that's a sad reality, right? We need to be able to be with people in such a way, right, that they don't feel the need to hide certain aspects of who they are in order to keep the relationship intact. So to show you this real quickly, they characterize these 5 things, the 5 good things that characterize growth fostering relationships. And again, talking about this because these are the types of relationships people need to have if they are going to be healed from adverse childhood experience. Each person feels a greater sense of zest, vitality, or energy. Each person feels more able to act, and they do act in the world. Each person has a more accurate picture of her or themselves and the other person. Each person feels a greater sense of worth. Each person feels more connected to other persons, and they exhibit greater motivation to connect with others. Okay, so this is the last thing that I'm going to share, and then we can go into the question and answer. A friend of mine, Dr. Jude Austin, he's a counselor educator, mental health counselor down in Texas at the University of Mary Hardin-Baylor. He did his dissertation and subsequent research on really the best therapist, right? So he actually interviewed several people who were rated as top-notch therapists. We call them therapists. So like a person like me, when I need to go to therapy, I need somebody really good because they need to be able to detect the BS, right, that I'm going to give them, right? So what he did is he interviewed several of these top-notch therapists, and he was really just trying to get at what do you do, right? And he asked other people, what do they do so well? And he came up with these 3 things that create what he calls therapeutic presence, okay? I call them growth fostering presence because I realize all the best teachers do this, right? All the best counselors do this. All the best pastors and chaplains, they do this. They're able to be aware of 3 things while they are interacting with others, okay? So when I am engaged in pastoral care with someone else, first of all, I'm able to be aware of what's going on inside of me in the present, right? So as I'm engaging, right, I don't want to get lost in my thought of who I am, right? But I am able to engage as I'm having a discussion with you. You know, is there something going on inside of me, right? Do I have strong feelings or there thoughts? I'm also able to, as I'm relating to someone, I'm able to kind of have a hypothesis or able to discern maybe what's likely going on with you, right? What's going on inside of you in this present moment. And the third thing, right? And there are a number of people who aren't able to quite get this, okay? But the third thing is people who are able to create what he called this therapeutic presence. I'm calling it growth fostering presence. They're able in the moment to pick up, discern the way we are affecting each other in this present moment, okay? So I went through 2 years worth of marital therapy training, right? So as a counselor, emotionally focused therapy, Susan Johnson, some of you will be aware of her work. So I went through that EFT training. And when I look back at my friend's work, Dr. Austin, I mean, this is what we're trying to train couples to do, right? When emotions get heated, can they, right, detect what's going on inside of me in the present? Can I hypothesize maybe what's going on with my partner? And then how are we influencing each other, right? Not just what are they doing to make me angry, but how are we influencing each other in the moment? I always like to give this when I'm talking to helping professionals because I think it might be the most valuable thing I say. Okay, so that's all I have. There are some documentaries here. Again, you'll have the link to these slides. These are documentaries that talk about mainly ACEs, and then always let people know about the Spoken Project that's free on YouTube, and brief videos dealing with racism. Okay, so I will stop there and let Mary conduct the discussion.
Hi, everyone. I apologize for the light in my room. It all of a sudden got sunny here in Boston, which is nice in January. Thank you so much, Dr. Brown. This is such important research, especially for those of us who not only study, but work with trauma and stress responses on a daily basis. So thank you. We do have several questions coming in. So I will start first with Rabbi Justin Kerber has 2 just clarification questions. And the first of those is he just wants to clarify something that you said is he's asking that so over half of the US population reports at least one ACE.
Yes.
Is that true? Okay. Yes.
That is true. And one of the things that they were surprised by, even by that initial study, again, these were people who were living fairly comfortable lives, right, as adults, that ACEs was much more common than what a lot of people would think.
Great, thank you. And Rabbi Kerber, also just another clarification question, wants to know if we have defined what burnout means for this discussion.
Yeah. You know, we have not for this discussion. A lot of times burnout is described as both a, I think at the core of it, when you look at the experts, they describe it as a sense of not being as effective in one's work. And then this general sense of tiredness, of weariness in one's work as well. So, yeah.
Thank you. And Rabbi Kerber, if you have more that you want to say about that, please chime in. And then Sophia Amina Muhammad has several things to say. Really important comment here in question. They say, as a parent of autistic sons and as an interfaith disability rights advocate, I have found that children with disabilities are underrepresented ACE research, especially Black and Brown children with intellectual and developmental disabilities. Can you speak more to this? Is there a shift in prioritizing that research?
I haven't seen that, okay, myself, but again, I mean, there are dozens of studies that are coming out each week on this, but it is true. I'm teaching the career counseling class, and I'm actually trying to do some research now on those, on persons with disabilities, and we lack research there, and it's sorely needed. We do know that persons who struggle with disabilities, particularly from childhood, they are more likely to suffer from traumatic experiences, right? Sexual abuse, physical violence, both from peers and adults. And so, unfortunately, I do not know of any major research there, but that does not mean it doesn't exist. If you would like to email me, I would be more than willing to do a quick research study, not a study, but look up and see if there are any articles on that.
Thank you, Dr. Brown. Is your email located in your bio that we
not
shared? Okay.
Put it in the chat window.
Thank you.
brown1@bu.edu.
Thank you. And then from Mallory, we have, this is a really great question. Could you say more about dose response? This came up several times. What exactly does this mean?
Yeah. What does this mean? And so the ACEs, you have potential from 0 to 10, right? That's your score. And each of those items, they only count once, right? But what they mean by the dose response is that if a person has a 1, let's say a person has a 1 and another person has a 2, even that additional dose, that additional number, it significantly increases the chance of there being physical or mental health problems later on, right? So the difference between a 2 and a 3 may not sound that much, but each number that it raises, there's a statistically significant chance that a person is more likely to struggle with mental or physical health problems. So in some ways, your ACE score matters. It really does matter.
Yeah, thank you. And Rabbi Kerber has come back, and this was a really interesting point that you brought up earlier on in your presentation when you talked about the idea of ACEs affecting adult behavior being un-American. And I think that he would like for you to just go back to that and say a little more about that.
I want to meet the rabbi. Please email me. We need to talk. I get the impression I would like the rabbi. I was doing this presentation for the first year. I was talking about it with my friend. Like, do you know about this? There's so many studies on this, right? And I partly gave you all this information. I gave it to you really quickly. It can be overwhelming. I do apologize. I try to give hope even at the beginning before I give it at the end. I have to tell you, the first time I taught, this was, maybe I shouldn't even be telling you this, but the first time I taught it, actually the PCEs, I didn't know about the positive child experience. So I taught it to my students, and I had 2 of my students go to the counseling center on campus right after. They were so discouraged. Okay. But I noticed over the years that it wasn't just some people being discouraged, but there were some people, they just didn't like it. They blew it off. And I don't want to hear that. Okay. And these were people who hadn't even, I hadn't even told them what the ACEs were. And I began to realize that there's a part of us, particularly people who are well-to-do, right? Again, we do not want to believe that the past is affecting our present or could very well affect our future, okay? And we certainly don't want to believe that what other people have done to us will affect us, right? We kind of have this independent spirit. I think as Americans, we focus much more so on the future, right? The big mindfulness craze, right? That I'm on that train myself, right? We have to talk about mindfulness so much because we're always so focused on the future, or if we struggle with depression, we're stuck in the past, okay? But the past really does influence where we are today and where we may be tomorrow. Something I didn't say is this. I'll just use an example. My dad was diagnosed with colon cancer this past November, had a surgery. He's doing very well. But in the midst of this cancer scare, I knew that his older brother, my uncle, died from cancer. I had forgotten that his mother, my grandmother, died from cancer. And I didn't know that his grandfather, my dad's grandfather, died from cancer, right? This puts me at a high risk. Right? Some people find out that you have heart disease, in your family. Your past does not determine your destiny. But what this does mean is I have to be really careful what I eat, okay? And that's what I want to tell people when it comes to ACEs. If you have a higher ACEs score, right, you just need to take some precautions, right? You need to know that you may be more susceptible to some struggles in the future.
Yeah, thank you. We have lots of questions coming up. Someone would like to ask, why were certain childhood traumas not included in this?
Sure. I do not know that, right? And that's a question that I always get. It's not just a question I get, it's a question that I have. I remember when I first read, I'm like, hold on, this can happen, but this can happen, but this can happen. These are the 10 that they landed on, okay? I don't know why others were not included. That what we know is that there are other factors. People bring up, what happens if you have a parent who dies, right? Obviously, a child who has a parent die, right? Or a sibling die, right? That's an adversity that's going to have a significant impact on their mental health, certainly not their physical health. I'm not sure why others were not added.
Thanks. We also have someone really interested in the Austin study, the Jude Austin study, and would like the citation for that. I would also like that citation, so I was going to email you later.
Yes, sounds
could,
good. Email me,
okay.
And I'll be sure to tell Dr. Austin, that people are wanting his study. Yeah.
Right. Okay. Thank you. We'll just email you that. Next, tremendous presentation. We're getting lots of great feedback for this, so thank you. This chaplain works with people who are adversely impacted by homelessness. Many present mental health issues, ACEs, substance abuse, and variety of biomedical issues. How do we prioritize which issues to address within the context of pastoral counseling?
Wow. Yeah, and I don't know how you would tease those issues apart, right? I don't know how we can do that. What I do believe is that, and I'm seeing some questions here. What about religious trauma? Those who have been harmed by that. I'm not aware of those studies, but those studies certainly need to happen, right? And I'm willing to help anyone who wants to be a part of that. But what I will say is that I think religious communities, we have part of the antidote, right? And that's to help create and foster these relational groups. What I do know is that when you're working with persons who suffer so much adversity, so much trauma, it's going to be important to for them to be surrounded by several people, not just one person, who is caring for them. Okay. And so, for example, a religious community I'm a part of, we are getting involved with and interested in foster care. Okay. And what a lot of research is showing is that if you really want to be engaged in foster care very well, you need to have what some people call a wraparound community, right? So it can't just be the parents who are fostering this child. There needs to be about 3 or 4 other adults, right, who are tied to these parents who say, okay, listen, I'm willing to pick up the child, periodically. If you need to go somewhere, if there are emergencies, you can call me. Okay. When we talk about so many other, and I heard, maybe some drug addiction issues and other issues, I don't know how you tease all of that apart. As a therapist, we talk about the biopsychosocial spiritual model. Okay. All of those 4 or 5 things, they need to come into play. My anecdotal experience is we try to treat all of those, I try to connect people with religious communities if they have that background. Okay. And you don't know which of those items that a person is going to struggle with, which of those items, if you press that lever, you might get more results from. You just don't know. So you have to try to address them all. Yeah. Sorry, I couldn't answer that question better.
That's a tough question. I think we're all asking. Is there any research that speaks to how a parent's ACEs score affects or is passed on to their children's?
Now, that's a question I can answer. Okay. We do know, unfortunately, that parents' ACEs score is likely to affect the child's ACEs score, right? So if parents have high ACEs scores, their children are likely to have high ACEs scores. And that's for a number of reasons, right? A lot of it is environmental. Some of it has to do with relational. Something I didn't say before, that actually neglect, that's one of the ACEs. Neglect is actually a major form of childhood trauma. I'm going to use the word trauma that quite often does not get thought about. Okay. So when parents have a high number of ACEs, it is extremely hard for them to be a consistent presence. It's not impossible. Please, again, it's not impossible. Right? There's some very good parents who have high ACEs scores. But many of you all will know about attachment theory, John Bowlby, right? If you don't know about attachment theory, somebody needs to do a presentation on attachment theory, okay? But it can be hard for a person, if they're a parent who have a high ACEs score, to be a constant, secure attachment for their child. And what I often remind people is this. I'm 46 years old. My parents were 72, 73. I was back home for 3 weeks during Christmas. It was wonderful. And I'm sitting in the living room with these people, and they are so relaxed, okay? They were not this relaxed, right, when I was a child, right? Because they were both working full time. They had little kids. They had me running around acting up, okay? And so it can be really hard for a parent with high ACEs scores to be that constant presence for their child.
Yeah, we have a really interesting insight here, going back to religious trauma, and that's that we're aware that some religious communities function as family, and faith leaders as parents. And so what if harm arises from religious communities?
Yeah.
Just thinking about that.
Yeah. So going back to one of the beginning slides, I talked about you have those 10 ACEs and they have those 3 categories, right? They have what they call abuse, neglect, and then household dysfunctions. What we know through research right now is that the abuse and the neglect, those tend to even have more harmful effects than household dysfunction, okay? And we know that abuse and neglect, I actually work with a lot of clients who they are still deeply hurt because their pastor did not visit them, right, when they were in the hospital. That is significant neglect, right? There's some harm that is done there. And so when we talk about those relational images, right, from relational cultural theory, abuse and harm from church leaders, from church members, they can have a deep impression on who we are. And I want to be careful how I say this. A lot of times, people who are most hurt by religious communities were also hurt in their families of origin, okay? Their original families, right? And that's why there are some people as pastors or as chaplains who will be very hurt by you. And you're a little surprised maybe why, they're reacting the way they are. Some of that has to do with the fact that they may have been expecting something from you, right? And it rubbed up against a wound from their childhood, right? So that's also possible. So that we know that there are a lot of religious leaders that actually do real harm to congregants. But it's also true that some of that pain in the church is resonating from the pain of their family of origin, as we say.
Thank you, Dr. Brown. At this time, we are going to close the open session. Thank you all so much for joining us, especially everyone from everywhere. If you are part of the trauma responsive grant program, this is your time to get to have a more intimate session with Dr. Brown. So stay online. And we will see you. I'm not sure, Michael, can you give us some guidance here?
Yeah, sure. So, and I'm not going to pop back on screen, but if you are not part of the Trauma Responsive Congregations Project,